So pause this video and have a read. When you finish doing it, you can continue playing the video. Okay, so the first thing we would do is to check for the rhythm. So let's see if it's regular or irregular. Remember in my last video I said get a strip of paper and mark 3 points. So 1, 2 and 3. Then slide your paper to this point and see if the next points match. So they match. So the points match, the points you marked already match with the other QRS complexes. So we say this rhythm is regular. So what type of rhythm is this? Is it sinus? Is it atrial? Is it ventricular rhythm? Or is it junctional rhythm? So first of all, let's see if it's supraventricular or ventricular rhythm. So the QRS complex is normal, is less than 3 small squares, so that it has to be a supraventricular rhythm. And if you look at the P wave, there's a presence of normal P waves. So we say that sinus P wave is present and then QRS is normal. That will be a sinus rhythm. Watch my previous video, which gives a longer explanation of how to understand and remember types of rhythm. So we've calculated the rhythm. We found out the rhythm to be regular and sinus. Now the next thing is to look at the rate. So the formula for rate, so that's sinus rhythm. The formula for rate is 1500 divided by the number of small squares. So if you count the number of small squares between two QRS complexes there, that will be 21. There are 21 small squares. So 1500 divided by 21 will give you 75 beats per minute. Okay. Watch my video, my previous video on how to calculate rhythm. If it's how to calculate rate when the rhythm is regular, and how to calculate rate when the rhythm is irregular. Now let's look at the axes. So we go into lead 1 and lead 2. Both of them are pointing upwards, predominantly upwards. So we say if both of them are positive, then that has to be a normal axis, normal cardiac axis. Okay. Abnormalities of P wave. So P wave represents atrial depolarization. So if there's problem with the atrial depolarization, then there will be a problem with the P wave. So P pulmonally, remember the pulmonary circulation is on the right side of the heart. So if there's P pulmonally, it signifies right atrium hypertrophy. So right side pulmonary circulation, right atrium hypertrophy, and the P wave is very tall, so we say peaked P wave. So P pulmonally start with P, peaked start with P as well. That's how I remember peaked P wave. If you look at a normal P wave there, you can see the P wave is very tiny. This one is about 1 small square tall. But if you look at this P wave, it's about 5 small squares tall. That's very tall. So we say in this case there's P pulmonally, and this would be a sign of right atrium hypertrophy. P mitrally, so you see a broad bifid P wave, like this. So you see M shape, it's like M shape. Remember the mitral valve is on the left side, so that way you can remember that P mitrally is left atrium hypertrophy. And if you see M P wave, if the P wave looks like M, just remember mitrally starts with M as well, so that can make you remember. So now let's look at the QRS complex. The QRS complex can actually be complex sometimes, so let's try to break it down. The first thing to know about depolarization, so QRS complex represents ventricular depolarization, And whenever before the ventricles become depolarized, remember the wave of depolarization comes. So starts from there, from the SA node, and then spreads to the atrium, and then gets to the junctional node or AV node, and then goes to the bundle of E's and then the bundle branches. So when it gets to the bundle branches, the septum is depolarized first. So before you get depolarization of the ventricles, you get the septum being depolarized first. This is very important, as you will see later on in the video. So the septum is depolarized first before the ventricles. And as you can see in this diagram, the arrows are pointing to the left. The arrows are going from left to right. If you see the three arrows I've drawn there, they are going from left to right. That's to say that the septum is depolarized from left to right. Okay. And another thing that needs to be on, another concept that you need to understand is that the average, I've already mentioned that the average wave of depolarization is towards the left ventricle, because the left ventricle is bigger because it has to pump blood around the whole system. The right ventricle just needs to pump blood to the lungs, which is very close, so it doesn't need to be very muscular as the left. So because the wave of depolarization is more to the left wave of depolarization tends to override the right one. So whenever you attach an electrode to the right side of the heart, it will be picking up the left wave of depolarization. It won't pick up the right. Yeah. So the left ventricle exerts more influence on the ECG pattern than does the right ventricle. So this is what happens in a normal ventricular depolarization. So the septum is depolarized first, the septum depolarizes from left to right. And then you also have to know that the left ventricle, the electrical activity of the left ventricle has a major influence on the ECG pattern. Okay, so based on this, let's try to work out the shape of QRS complex in chest leads, because they actually differ. So let's say we attach a V1 electrode, which is looks at the right ventricle. It's a right ventricular electrode. So the wave of depolarization comes. So V1. So that's the segment between the P and the QRS complex. So the wave of depolarization comes from the bundle of E's there and then to the bundle branches, and the septum is depolarized first. The septal wave is actually very small. It's very, as you can see from this arrow, my arrows are quite small. But V1 will pick you up still, but it will be a small positive deflection. Whenever the wave of depolarization is moving towards an electrode, there will be a positive deflection. If the wave of depolarization is moving away from an electrode, there will be a negative deflection. Okay, so V1, the first wave it picks is the septal wave of depolarization, so there will be a small positive deflection. And remember, if you watch my first video, a positive wave, the first positive wave of depolarization, the first positive deflection is known as the R wave. So you have a small R wave in V1. Okay, now after the septal depolarization is complete, you get the ventricular depolarization. And remember, I said the left ventricle is one that takes charge, so this will be measuring, V1 will be measuring the electrical wave, the wave of depolarization in the left ventricle. And because this wave of depolarization is traveling away from V1 electrode, that will cause a negative deflection downwards. So you can see that negative deflection, and from my definition in my first video, the negative deflection below the baseline after an R wave is called an S wave. So that's an S wave, and then after this the ECG just goes back to the baseline. So in this case we have an R wave and an S wave. There's no Q wave in this. Yeah, good. If you notice from this, V1 has a very short R wave but has a very long S wave. That's very important. Now let's go to the left ventricular leads. So let's take V6 as an example. So V6, the first wave of depolarization that V6 will measure will be the septal one, because the septum is depolarized first. The septal wave is going away from V6 electrode, so the deflection will be downwards because it's going away from the V6 electrode. And from my definition in my first video, the first downward deflection after the P wave is called the Q wave. So that's a Q wave there. Okay, so it's picked up the Q wave. Now when the septum is completely depolarized, then you get the ventricles being depolarized, and the V6 electrode will be picking up this wave of depolarization. This wave of depolarization is traveling towards V6, so it will be a positive deflection. So there will be a large positive deflection, and what wave would that be? That will be the R wave. Yeah, and then you go to the baseline. That's it. If you compare V1 and V6, V1 has a very small R wave, V6 has a very long R wave. V1 has S wave, V6 doesn't have S wave, but sometimes you do get S wave in V6, but then the S wave is really short. This is just proving a point that the S wave is short, so you might actually not get an S wave in V6. Also, you would notice that V6 has a Q wave, V1 doesn't have a Q wave. So just remember, the septum is depolarized first, and the wave of the septum is depolarized from left to right. And then also remember, the left ventricle is the one that determines the average wave of depolarization of the ventricles is in the direction of the left ventricles. And then you can easily remember how to draw this. And this is very important when we talk about something called R wave. So if you look at this ECG strip, you can see there's a small R wave there, followed by a long S wave, that's V1, small R wave, long S wave. And you would notice that the R wave is actually increasing as you go from V1 to V6. So you can see the R wave is increasing there, the R wave is increasing there, there, and then there. So when you go from V1 to V6, you get an increased R wave, and the length of R wave increases. Okay. Also, you would see that the S wave is getting smaller. So that there's an S wave there, and then it gets smaller. There's very little S wave there, there's no S wave there, and there's no S wave there. So R wave, in normal R wave progression, you should get a gradual rise in R wave across the chest leads, and then you should get a gradual decrease in the size of S wave as you go from V1 to V6. There are various things that could cause poor R wave progression. We'll talk about them in future videos. Now let's talk about, there's something called pathological Q wave. Remember, I said Q wave can be normal. So Q wave can be normal in the leads that look at the left ventricle, because they pick up the first septal, so they pick up that wave of depolarization, and then the left ventricular leads will be the lateral leads, also known as the left ventricular leads, will be picking that up first. So you get a very tiny Q wave, which is normal. So it's normal to see small Q waves in lateral leads. Remember, the lateral leads, they are lead 1, AVL, V5, and V6. Okay. However, if you see, let's say there's a myocardial, by the way, pathologic Q wave is just a sign of an old myocardial infarction. So if you see if you see abnormal Q wave on an ECG, is a sign that the person has had a myocardial infarction in the past. So let's look at this. So that's V6, and this is what you should get normally. So you get a small Q wave and then the R wave. But let's assume there's a myocardial infarction. So if there's a myocardial infarction, the muscle is necrosed. So there'll be a window from there. So there'll be a window in the ventricles. There will be no electrical activity in that part of the ventricle. However, the septum is still being depolarized. So V6, the only wave V6 will be picking up will be these Q waves. Yeah, so the graph will look like this. So that's a P wave, and then to pick up the Q wave there. Can you see how deep the Q waves are? The Q waves are very deep in this, and then it goes back to the baseline. So that's what pathological Q waves is. Okay. Now, Q wave is abnormal. If the Q wave is more than 1 small square wide, then it's abnormal, regardless of the lead. Or if it's more than 2 millimeters deep, so it's quite long, 2 millimeters, so 2 small squares. If it's more than 2 small squares deep, then that's abnormal. And from my previous slide, I said the right ventricular leads don't pick up Q waves because there's no Q wave. They are measuring this straight away, so that should be an R wave when they pick up the septal wave of depolarization. So if you see Q waves in lead V1 to V3, that's abnormal. Okay. However, sometimes, even though lead 3 is an inferior lead, it's actually a normal variant to see Q wave in lead 3. So let's say look at this ECG. Can you spot any? Pause the video and see if you can spot any Q waves. Okay. So I'm going to circle all the Q waves. There's Q wave in, you can see how long that Q wave is. So lead 3 has a lot of Q waves, and then AVF as well. That's very long. And then lead 2. So you can say this person had an old MI. So which part of the heart would you say this person had an old MI in? So which part of the adult lead 2, 3 and AVF look at? Is the inferior lead. So I'll say this person had an old inferior myocardial infarct. Okay. And for you to say something, for you to confirm that there's an old myocardial infarct, the concordant leads must you must have at least 2 concordant leads saying there's an old infarct. So for example, if I only have Q wave in lead 2 and I don't have any in lead 3 or AVF, then I can't say there's there's old infarct. You need at least 2 from maybe the inferior lead, or at least 2 from the anterior leads, or at least 2 from the lateral leads for you to say there's an infarct in that part of the heart. So you need 2 leads to say that. If you notice there, that's actually not a Q wave. There's a bundle branch block. There's a wide QRS complex. There's actually a right bundle branch block. We'll talk about this in a future video.